All right, welcome everyone to the conversation series from the Alliance as we focus on today's topic, donation after circulatory death in heart transplant, the case for normothermic regional perfusion. My name is Corey Bryant. I serve as the Senior Director of Communications here at the Alliance, and I am excited to be your host for today's program. Just a quick note before we get started, the conversation series is designed by the Alliance to be an opportunity to showcase and discuss new innovations and effective practices across our field. However, it's important to note that the Alliance is not an advocacy organization, and we always intend to maintain an objective and unbiased perspective in all of the information that we bring to you. With that, it is my pleasure to introduce you to the moderator for today's program, Karen Lord. Karen is an advanced practice donation specialist at New England Donor Services. And Karen, thank you so much for being here today. And it's my pleasure to hand things off to you.
Okay, thank you very much, Corey. So good afternoon to all who are on the line and welcome. I am honored and very excited to welcome and introduce Dr. Ashish Shah, who is presenting, as Corey said, donation after circulatory death in heart transplant, the case for normothermic regional perfusion. Dr. Shah is a professor and chair of the Department of Cardiac Surgery at Vanderbilt University Adult Hospital in Nashville, Tennessee. He holds the Alfred Laidlaw Endowed Directorship in Cardiac Surgery and is the medical director of cardiac surgery, OR, POD, and heart transplant surgery. Dr. Shah grew up in New England, in Connecticut. He received his bachelor's degree from Duke in biomedical engineering. He received his medical degree from the University of Pittsburgh School of Medicine and then returned to Duke for an internship, followed by residencies in general and thoracic surgery, where he was exposed to heart and lung transplantation. This experience led him to Johns Hopkins University in Baltimore, where he performed aortic surgery and heart and lung transplants. He then, in 2015, relocated to Nashville, where he is now, to serve as the medical director at the heart transplant program in Vanderbilt. Dr. Shah has been focused on establishing the Heart Transplant Center as an international destination for patients with complicated diagnoses. As their program has grown, doors have opened to participate in more cutting-edge research. This has led Dr. Shah and his team to, quote, thinking outside the box and DCD heart recovery, which Dr. Shah will share with us today. I also wanted to comment, I know that Vanderbilt was very in the forefront of accepting Hep C hearts, which was another great move forward for people waiting. Dr. Shah has been described as a physician who has, quote, a heart for transplant patients. And I think we will see that and hear that today. I am again honored and excited to introduce Dr. Shah. Welcome.
Thank you, Karen. Very kind remarks. And I really appreciate the opportunity to speak to everybody today. And the invitation by the Alliance is very, very kind. I think the work that your organization is doing is really critically important. I firmly believe that we are on the verge of another great leap forward in transplantation. And we'll talk a lot about DCD and normothermic regional perfusion, but I hope what surrounds this and what kind of hovers over all of us is another great leap forward for this in this century in transplantation. So thanks again, and let's get started. Okay.
I just need to flip to
See, I told you it was going to happen.
opposite view.
Okay.
No worries. Thank you.
Okay. Well, again, thanks for the opportunity. And what we're going to talk about today is this notion of donation after circulatory death and the use of normothermic regional perfusion to really utilize hearts that we've traditionally not been able to utilize. And so I'll review a little bit of our pathway and our journey here at Vanderbilt, but I think this is really going to amount to an international effort to grow what is a potentially powerful source of new organs. But I also think behind all this is us understanding how to resuscitate all organs. And maybe really the future here is what we're going to learn from this experience is what's going to help us take care of lots of people with advanced heart, lung, liver, and kidney disease. So as Karen had alluded to, our program at Vanderbilt has seen some significant growth. Over the last several years, we've had a really dramatic increase in heart transplantation at Vanderbilt. And we sort of began to look for and explore atypical donors. Don't like to say high risk anymore. I don't know what that means anymore. So I think these hearts are always better than the hearts we're taking out. So I think that this notion of high risk and low risk is, I think, honestly, is a 20th century notion, and we got to move away from there. So the hepatitis C experience at Vanderbilt was a robust one, taking hearts that would otherwise thought to be unusable, exploiting really a remarkable thing, and that is these drugs, these antivirals that cure people of hepatitis C. I think it was one of the things that, I mean, truthfully, one of the things I'm really most proud of that we did as a group at Vanderbilt is have all the right people in the right places to say, you should think about this. And as our program has grown, it did give us some opportunity to explore DCD organs, that is donation after circulatory death. And as you can see with our own volumes, while hepatitis C donors are a fundamental part of our work, you see this growth in DCD, and we'll talk a lot about that today. So for those of you who don't know me, I'm somewhat obsessed by rock music and in fact, rock history. And I think there's important lessons to be learned from rock and roll. And so in many ways, I think NRP and maybe our program at Vanderbilt is a little bit similar to this band. This is the 1970, 71. This is a small band out of Pasadena, California. And I don't know if anyone knows who these guys are, but this is what it sort of felt like when we started our thinking about DCD and even the notion of hepatitis C hearts, that we were sort of a small outfit. Nobody was really paying much attention. We got a couple of people sitting and watching, but that's about it. Meanwhile, the biggest band in the world at this time is Led Zeppelin. I don't care what you say. In 1974, these were the guys, biggest band in the world. And in some respects, this is sort of the traditional big centers that were around in transplantation, but really brain dead donors. And that represents the big, the big elephant in the room as far as where donors are coming from. And as you can see, Zeppelin in those years, this is Madison Square Garden. This is the audience that they were playing to, and in some respects, this is it's a metaphor of suggesting that our thinking about organ donation really is couched in this world of brain dead donors. And what DCD and in particular NRP does for us is really change. It's going to change the theater that we work in. So before we start, and because we've got a very broad audience, we're going to have a number of terms that we're going to use here. So first, DBD is donation after brain death, very conventional donor. Brain death, we can all acknowledge, has some objective criteria. A donor is declared brain dead, and then that allows them to donate their organs. DCD is this notion of donation after circulatory death, that you allow a patient to pass away, and then you can use their organs. Little c DCD is controlled DCD. Now, as it turns out, for those of you who don't know, there's lots of different flavors of donation after circulatory death. Someone could pass away in the street and then come in with chest compressions into the emergency department, a so-called uncontrolled DCD. So what we're going to talk about today, though, is controlled DCD or CDCD. NRP, I've already referenced that, is normothermic regional perfusion. And what we're talking about is the in situ resuscitation of a donor using extracorporeal circulation. And then OCS is the organ care system. That's the heart in the box people talk about, designed and implemented and wonderfully managed by the Transmedics company in Andover, Massachusetts. OCS is the ex vivo or ex situ machine perfusion of hearts and other organs, but really hearts are what we're going to talk about today. So this is the glossary terms I'll have to think about as we explore this. So DCD is not new. And in fact, the first organ donors were DCD donors. And I urge everyone to look at Christian Barnard's case report of the first human heart transplant. It's fascinating. And it turns out, and this is, I have a little snippet from that case report about the donor. 2 adjoining operating rooms, each with a pump oxygenator, were used. The death of the donor was determined by the absence of reflexes, spontaneous respiration, electrical activity. After death had been ascertained, the donor's chest was open and she was connected to a heart-lung machine primed with Ringer's lactate. So this is fascinating. The first donor for the first human heart transplant in South Africa, first of all, they co-located the donor. Secondly, once that patient had passed away, they put that donor on bypass, began cooling, and then began essentially priming the heart and other organs for transplant. And so that was really the standard practice in many ways of heart transplantation in donors. Until 1974, and this is the notion of brain death. And the critical legal case here is this one. It's Tucker versus Lauer. And Tucker versus Lauer is a little bit of a sad story, frankly, of a patient who had what the team at the Medical College of Virginia in Richmond felt was a terminal brain injury, had viable organs for transplant. They actually couldn't find anyone to give permission. And so they just went ahead and used the organs. And the family sued them. And Richard Lauer, one of the great pioneering heart surgeons and transplant surgeons, was named in this lawsuit. Actually, the prosecutor for the case was Douglas Wilder. Some of you may recall, eventually went on to become the governor of Virginia. Well, this case is important because it establishes the notion that brain death in the United States, first of all, is a thing, and that the permanent injury to the brain, despite the heart beating, is still a state that allows a team to use those organs for transplantation. So this is a big deal because, for all of history, death is really when your heart stops. This case and the notion of brain death changes that completely. Brain death wasn't a thing, that we've had for centuries. That's a new thing. And frankly, Tucker versus Lauer tells us that we do create really states that allow us to offer these organs for transplant, provide a greater good, when we know that there's permanence there, that it's not plausible that these patients will survive to have any meaningful life. It's important. And nonetheless, and so from this case in the United States, brain death becomes the dominant mechanism to have organ donation. Without brain death laws or the acknowledgement brain death exists, we wouldn't have transplantation the way we have it today. And those countries now that struggle with brain death have very low rates of organ donation as a result. So we're very fortunate in the United States that we were able to explore this. Well, so the DBD donor becomes and remains the dominant source of organs in the United States and in the world. But a very pioneering team at the University of Colorado looked at this notion of using hearts from babies that pass away and use those hearts, thinking that, well, it's a baby's heart. They should have some resilience and reserve, that even after letting the patient expire and the heart stop, you could snatch that heart, use it, and it should work. And in their series, I think it was probably 3 patients that was published in the New England Journal, they had a very satisfying experience that this is usable. Because for those of you who don't realize that if we let someone pass away, well, then the entire body and all the other organs are now ischemic. And so, of course, for abdominal transplant, we then, once we say, after the standoff period, once the donor's been declared dead, we can go ahead and rush in and take those organs and use them. But taking a heart doesn't sound like such a great idea because the heart would be ischemic and it's just sitting there and it's never going to work. Well, the team in Colorado really helped us understand that these organs are actually viable, maybe in pediatrics, but clearly there's a possibility there. So these are very important experiences that lead to what comes next. And really, it's pioneering efforts in both Australia and the United Kingdom that brings us to where we are today. And so those teams, both at Papworth and in Australia, really were able to, and largely because of the growth of machine perfusion, the OCS system. So you can allow a donor to pass away, you could take that heart out of there, and then put it on an ex vivo, ex situ apparatus to resuscitate that heart and allow you to assess it. Well, these teams said, well, wait a minute. Now, if I don't have to worry so much about the heart being ischemic, not getting enough oxygen in blood, let's go back to these donors and take advantage. Because recall that in the UK for many decades, they had a decline in total organ donation. They were really struggling. And those teams had to find solutions to meet the demand of patients. And so utilizing the strategy, they began with using ex situ preservation techniques in these DCD donors. And what they found essentially is that the survival was quite good. They had very good results. Now, the one worrisome thing was that there was a 30% incidence of requiring post-operative, post-transplant mechanical support or ECMO, meaning initially those hearts were not working so well that they needed some form of mechanical support, in this case, ECMO. So a little bit of a signal that although in the long run, they seem to be working okay, maybe early, not so great. And is that a problem? Well, the Papworth team really continued their really pioneering efforts in this field and included an arm utilizing normothermic regional perfusion. As you remember from our glossary of terms, this is the in situ resuscitation of these hearts, make sure they're okay. They, in fact, would put a Swan-Ganz catheter. This is after the patient is declared dead. They resuscitate the heart in situ, put in a TEE probe in there, look at echo, look at Swan-Ganz measurements, reassess the heart, and then remove that. If they were close enough, they would just use cold storage. If they were in any distance, they would put those hearts on the machine perfusion, on the OCS system. And their results, and this is really a really landmark series, showed very good results between DBD donors, conventional donor, and DCD donors. And remember, these are hearts that would otherwise be discarded. This is a brand new source of potential organs that seem to work very, very well. Interestingly, they also saw a 30% incidence of enough allograft or heart dysfunction that they required some mechanical support. Now, importantly, most of these patients just needed a balloon pump. And so I think there's an important trend here that we're beginning to understand how to manage these patients better. And in fact, with better outcomes, we now have really opened up an avenue here, a new source of organs. Now let's think about that a little bit. So this is just my back of the envelope calculation of thinking about how many potential hearts are there out there. So I was actually surprised. I just looked this up today. There were over 4,000 DCD kidney donors in the United States. This is actually from 2019, there was about 2,000. So this is a dramatic increase, which is great news for everybody. And if you said, well, why don't we just look at donors that we would consider, as far as age is concerned, appropriate for heart transplant? So between the ages of 18 and under 50. Well, that's about 1,900 kidneys. Just for those of you, so obviously if you do the math, the great increase in DCD kidney donation is actually in older donors, so that was interesting. And if you take this 1,900 and say, look, maybe 30% is going to get us a viable heart, although I think that number ultimately will be higher, that's still 500 hearts that we don't have. Now recall, we do about 3,500, a little under 4,000 heart transplants in the United States. So adding 500 is not a trivial number. In comparison, where we thought the use of hepatitis C infected donors into hepatitis C naive recipients would be a big bump. It's really only a couple percentage points. So this is real. 500 or more hearts, yeah, and I think actually this number of that 1,900 is probably going to be closer to 1,000, just based on our experiences that we've had at Vanderbilt. So what are the potential advantages of a DCD donor? Well, first is going to be the obvious. There's no brain death for the most part. And all the inflammation, the secondary changes that occur with brain death won't be there. So that's got to be good. The other advantage is these hearts are not getting utilized. We now use livers, kidneys, lungs from DCD donors. So now we can add hearts. And the other piece, and that's been our experience, and these are right now very high quality organs, meaning they're donors who may have had a very limited medical history beforehand that are young and really beautiful hearts. For those of you who do heart transplant, getting access to 20-year-old hearts has been very limited for decades. The average age of a donor in the United States are in their 30s, and in the UK is even older, in their 40s and 50s. So these are potentially very high quality organs. Well, what's the downside? What are the disadvantages? Well, the disadvantages are that you have that warm ischemia period. So as the donor was terminally extubated and we're waiting for that donor to pass, there'll be a period of time where the heart is not working very well, the whole body is not getting enough blood and oxygen. So that's potential ischemia, potential injury to the organs. With warm ischemia comes the risk of primary graft dysfunction after transplant. So we worry about this. And if you have warm ischemia, if you have primary graft dysfunction, what are the long-term risks? Will that accelerate graft coronary artery disease? Will it accelerate long-term phenomena of fibrosis and that sort of thing? And as I've hinted at, with all the devices we're talking about, the people, the logistics, this is going to be technically potentially challenging. And with conventional DCD recoveries, this is now not using any machines, just we wait for the donor to pass, we agree it's acceptable to recover the organs, and we begin that process, which is, it's a bit of a race to enter the abdominal compartment or the chest quickly, and then introduce our cannulas and then begin perfusing with cold preservation solution. So all that is a setup for risk of warm ischemia. And if the period of time between extubation, the agonal period, and the time we think it's that the patient's declared dead is too long, then frequently, particularly with the liver teams, they will not accept a ischemic time, an agonal time, any time more than about 30 minutes. So there's a risk of non-recovery. If you add thoracic organs to the mix, that adds complexity. And the other thing that we've certainly found is that there is not a lot of consistency with respect to the logistics around DCD donation around the country, meaning when are you allowed to prep, when may you extubate, what are the standoff times? All of these things can be potentially variable and will affect your ability to recover a heart from these donors. So as we talked about, the ex situ reanimation, the OCS system, does allow you to recover from a DCD donor. So again, we allow the donor to pass, we agree it's acceptable to recover the organs, and then begins a process. Again, the time is now of the essence. We need to open the chest, cannulate, remove a volume of blood to prime the ex situ circuit, and then we take the heart out using cold preservation solution crystalloid and reanimate it. And we reanimate it on the OCS device. And you have this, which never ceases to amaze me or be dramatic to all people involved, is that the heart has been reanimated. The heart that stopped, that was probably not working for sometimes as long as 30, 40, 50 minutes, can be brought back. NRP, the in situ recovery, is a little bit different. Here, we begin that rapid process of cannulating, but instead of cold preservation solution, we cannulate the right atrium and the aorta, and then use a mechanical pump with an oxygenator to bring oxygenated blood back to the rest of the body. In order to keep the perfusion regional, we exclude the cerebral circulation. We put a clamp across those blood vessels. So we're just reanimating and resuscitating heart, abdominal organs, lung only. It does allow us to evaluate the heart. We reanimate it, we reevaluate it. And importantly, this reconstitution of blood flow may actually help abort all the bad things that happen with the warm ischemia to the abdominal organs. So potential, really great potential here. Most DCD events have a particular timeline. This is taken from our paper and our initial experience. And so recognizing that probably the most important thing prior to withdrawal, that is the removal of the breathing tube, is being able to administer heparin. This also has some variability in depending on where you are, but really we think this is a critical piece to allow recovery of hearts, quite frankly, of all organs in this setting. And then we have a withdrawal phase, we have an agonal phase. Now, interestingly, the agonal period has historically been defined by a drop in oxygen saturation and blood pressure. What we've learned is that oxygen saturation, and our colleagues in the UK have really, again, led on this, is probably not as relevant as when the blood pressure drops. So we currently don't worry so much about the oxygen saturation, but really focus on the blood pressure. The donors declared dead, patients declared dead. We have a standoff time, the period of time where we do not believe auto resuscitation is possible. Really a phenomenal study, New England Journal tells us that it's not possible after 5 minutes. And then we get into the chest, cannulate, and then perfuse. And we'll tell you a little bit about our experience. And then after a reanimation period, which in our protocol is always 45 minutes to 50 minutes, we don't go past that. We think that's sufficient time to resuscitate all the organs and make it safe for recovery. We then proceed with our donor cardiectomy, just like you would a brain dead donor. We use Delnito solution that we learned from the OCS clinical trials, works great. And while our initial, and I'll talk a little bit more about this, our initial concerns about cold ischemic time was to try to keep it short. As we've learned, the cold ischemic, we've really converted a DCD donor back to a DBD donor, but maybe with some inherent advantages. We have been able to do this in under 3 minutes. So meaning from incision to reperfusion in under 3 minutes. And most people think that there's no way that's possible. I can promise you it is. And so I'm going to show this video, which is a real-time video. It's unedited of such a recovery. So you can see this is a huge donor too. You've got two teams that are working, the abdominal team and then the cardiac team. Interestingly, during this video, at some point, the abdominal team actually stops working because they're just kind of a little bit in awe of what we were doing up top there, I think. But you've got two cardiac surgeons working together. You see the heart is in standstill. Now there's no blood because there's no heartbeat. And the first thing that they're going to do is actually put a tube in the right atrium to cannulate the right atrium. And before that, we isolate the cerebral circulation. We just cut off the blood supply to the brain. And that ensures that this is a permanent state, that we're not going to restore blood to the brain in any way, and that this person is going to pass, no matter what happens from here on in. And it ensures a truly regional perfusion. We're just perfusing organs. So that clamp goes across the blood vessels of the arch. Now we cannulate the right, that's that purple thing there is the right atrium. We snip that and put one tube in there. One of the things that we think might be a great advantage of this technique is the venous decompression. Just putting a tube in the right atrium and draining the patient, you see now we're draining the patient back to our pump, is probably good for all the organs involved, because venous congestion we know is a bad thing. So now one assistant's holding on to that tube, and then now we're going to put a stab into the aorta itself and put another tube there. And that's our arterial cannula. So we're going to perfuse the body, and just the body, not the brain, and the heart with this tube. And so now the teams are, that one surgeon's holding everything together. It's the most important surgeon in the building. And then we connect this tube up. And then you'll see us start the pump. And you see red blood, restore blood. Now you can see the abdominal teams are able to work, but their organs are now getting oxygenated blood, stopping the ischemia process and potentially, and really slowing this down. Now, the dissection of the abdominal organs, the temperature comes way down, meaning in the room. Now, there's no rush. You can take your time and do these things safely. So this video is real time. It's only a couple minutes, and I promise you, we send multiple teams. They include fellows. This is very doable by all teams. And this is what you have. You have a heart that's resuscitated and reanimated. We're cannulated. We've excluded the cerebral circulation. We also introduce a cannula into the pulmonary artery, and that way it drains blood out of the lungs and protects the lungs, and also protects us from over-distending the right ventricle and the left ventricle. In our experience, we utilize what I call the eyeball test and no other test to assess whether or not that heart is viable. We don't introduce a swan, no echo. We just kind of eyeball it. And so far that has worked very well for us. We bring all our own equipment. This is our pump setup, and it's shown in our paper that has been published in the Journal of Heart and Lung Transplant. This is our setup. We get a lot of questions about how we have these things set up, but this is it. You're more than welcome to reach out to our team if you have questions about how we set up these circuits. We do bring a lot of our own equipment. It's a fairly heavy load of stuff that we bring with us. So how do we assess these organs? In situ, we can look at hemodynamics, meaning the pressure generated in the root of the aorta. We can measure that pressure. Some biochemistry, and this is an area that we do need a lot of work in. We tried to track lactates. It's a little bit hard to make some sense of it because, again, the abdominal team's working. They may have been already starting to clamp some blood vessels, exclude the circulation in the legs, so lactate's a little hard. Honestly, eyeball test has been tried and true, and we have rejected a couple of hearts because they just don't look very, very good. Ex situ, using the OCS system, gives you more data. You can look at coronary blood flow. You can look at perfusion pressures. You can look at lactates. And ex situ, we can support hearts for 6, 8, even 12 hours. So very powerful and a very different strategy. And if you had to compare the two, our initial thought was that, well, maybe if you had long distances, using the OCS system made a lot more sense. If you were worried about time, meaning that you had a long explantation of the heart, an LVAD, complex congenital work, maybe keeping it on the box would be a satisfactory system. Obviously, family consent is critically important, and there's going to be some work from a variety of organizations to make sure families understand what's happened. That in one instance, we're going to let someone pass and just take the heart out, put it on a machine and restore the heart. In another, we're going to restore that heart in situ in the body. Ex situ, because I said gives us time up to 12 hours, gives you an opportunity to recondition the organ. 50 minutes will only get you so far. Both of these require significant resources, but for sure, using the OCS system has an added cost that you don't have necessarily using the in situ NRP platform. But everything costs money. One of the things that we found somewhat challenging, actually, is predicting which of these DCD donors would pass, especially if we put some time constraints of 30 minutes on the agonal period. What we have learned is that reflexes are helpful, the absence of reflexes. Any breathing over the ventilator can be predictive of a donor that will persist past a comfortable time period. Any hemodynamic support's important because all that would be shut off. And then age, the younger donors, it's hard to predict with younger donors, meaning the 18-year-olds, whether or not they'll pass. I will say that with NRP, some of the time constraints, we've let that go. So whereas some instances after 30 minutes, historically we would have walked away, we've now moved to waiting as long as it takes, as long as anyone will let us before initiating. And it turns out even an hour of being in that sort of limbo time has yielded hearts that are totally acceptable. The Victor Pretorius' team at UCSD, University of California, San Diego, has also been real leaders in NRP on the West Coast, and their experience is similar to ours, where waiting longer is okay and it's worth it. So our initial experience has been published, and it's our first 15 cases. Jordan Hoffman led this effort, and it's published in the Journal of Heart Lung Transplant. So a lot of the logistics and some of the mechanics of our circuits are there for those of you who have questions on that. This is our updated experience. We've not published this. So this is, we've now done 51 heart transplants from DCD organs utilizing the NRP platform. As you can see, the average age is young, predominantly male. That agonal time in general is actually pretty short, although occasionally you have some that have gone longer than an hour. But consistently, our time from incision perfusion is 3 minutes. And again, multiple different teams. There's no magic. It's just a consistent approach that you saw in that video. Our recipients are very conventional as well. We don't tailor the recipient. Obviously, they need to acknowledge that they're getting an organ from a DCD donor and that there are risks of long-term things that are unknown, much like with the hepatitis C cohort that we have. Predominantly male. We don't have any bias about the types of recipients. So you can have an LVAD, adult congenitals. We really don't particularly care. And in grading the performance of these hearts afterwards, although it's obvious if a heart's not working because you're on ECMO or mechanical support, we're keen on looking at inotrope scores as another measure. And at 24 hours, our inotrope scores about 13, which generally is quite acceptable and if anything, pretty low for a heart transplant that early out. And it continues to go down over time. Our experience, frankly, is that these hearts work very, very well. We've had only one case of severe primary graft dysfunction. We did put 4 intra-aortic balloon pumps in this group of 51 patients, but part of that is our bias in general. We tend to favor putting in balloon. We have pretty low threshold, put in balloon pumps. Just given the volume of transplants we have, spending a lot of time in the operating room is a little bit hard for us. So we have a tendency to go to forms of mechanical support a little bit earlier. But nonetheless, in this small group, this 51, we really didn't use a lot of mechanical support. It's a lot different than that 30% that we've seen historically. We did have one early death, but that was actually due to intraoperative dissection on the recipient side. And really, and this is actually remarkable and consistent with the international experience, that we've not had any cardiac allograft related deaths within 30 days, and frankly, even longer. These hearts work very, very well. We've used kidneys almost universally from these NRP DCD donors. About half yielded livers. Many times the liver teams walked away just from that time constraint, and that may change in the future. 8 lungs were utilized. Our average distance now over 300 miles. We don't worry so much about distance anymore, and you can see our total mileage is 30,000 miles for our teams. We have pushed the boundaries on cold ischemic time as well. The teams in the UK have been trying to limit this. We sort of, because of where we are in the country, accept that we're going to be doing some traveling. And we've pushed our cold ischemic times as long as 4 hours in these donors, and they work very well. There was actually a remarkable week we had where we had 2 DCD donors, both in Colorado. One we recovered using OCS, one we recovered using NRP. Much of the demographics and everything else is very similar. You'll take my word for it. What we found with that was essentially both hearts worked very, very well. So both platforms seem to work well despite distances that are potentially involved. What about the abdominal organs as we start thinking about this more broadly? Well, DCD liver and other abdominal organs had been associated with historically very high rates of difficulties, particularly anastomotic stricture, that ischemic cholangiopathy. And in the European experience of using NRP, they found very good outcomes with respect to these dreadful complications. So maybe that reperfusion really benefits the abdominal organs. Well, the challenging part of NRP is that reanimation of the heart and thinking about what it means to be dead. Again, with a DCD donor, the idea is that you're not going to resuscitate this. You're not going to restart that heart because that would not really fit with what our notion of DCD is. And it really challenges us to reconsider that idea. Well, Arthur Caplan, who we can all agree is probably one of the world experts in bioethics, has put together a beautiful essay on all these concerns. And I really urge everybody to read this. I really think it nicely encapsulates appropriate concerns about that reanimation step, about excluding the cerebral circulation. I think the two key ideas as we reconsider our conventional notions of circulatory death is that none of these patients and ultimately donors are coming back. There is an absolute permanence to their condition. Number two, there is a stewardship, and that is that these families want to donate their organs. And these organs, as we have shown, I think pretty convincingly, as our partners in San Diego, in London, and in Australia, they're excellent quality organs that can help other people. So in thinking about this reanimation, NRP, we've got multiple constituencies. We have multiple notions that we need to be respectful of, but they certainly will be challenging. There's no question, and there's going to be work that needs to be done to clarify all the issues involved. But I do urge everybody to read this essay. It's really excellent. It's American Journal of Transplant, and you can see the reference there. So what does it take to build these programs? Well, you definitely need an infrastructure. And I have been very fortunate at Vanderbilt to have that infrastructure that was here when I got here. And really a leadership structure at the highest levels. Seth Karp, Wright Pinson, they're all both transplant surgeons that many of you in the audience know. It's been because of their support and institutional commitment we're able to do this. But you require a real perfusion group. You need surgeons, air and ground transport, as I said, institutional commitments. And as you can see there, the perfusionists are not any more happy to do these trips as they are to do other things. But boy, they are a cornerstone for our program. And without them, this is not possible. It's a mobile program. And you can see our ECMO circuit there heading off to a very conventional fancy airplane. But this is the team. This is what it takes to get you these hearts right now. So in conclusion, a extracorporeal support system in controlled DCD can simplify recovery. It minimizes ischemia, improves outcomes, and potentially increases our yield of potential organs. We're going to have to think about ex-situ and in situ platforms. I think a high volume program is going to require both. There is more opportunity ex situ because we have more time. We can manipulate those organs, potentially cleanse them. We can move them to the right recipient. Time doesn't matter. So if the better recipient is in Alaska, great, send it to Alaska. So I do think that the future ultimately will be an ex situ platforms. The one thing that's a little bit nagging that we haven't figured out is why are these hearts better? You can say, well, there's no brain death. That's probably good. But we've done a number of NRP recoveries in brain dead donors because that's what the family wanted. They requested it. And those hearts work great. Is it because the age is young? Maybe. That's probably a big part of it. Is it the perfusion? Maybe. Is it because the hearts are unloaded? The whole system is unloaded, that you don't have that venous congestion. I think there's something to that. That might be why, even in a brain dead donor, the hearts are working better. Time will tell. So that band that nobody was paying attention to, well, they turned out to be Van Halen. So this is them in 1980 at the Oakland Coliseum. So in many respects, NRP feels like this, where everybody's sort of paying attention, and it seems like we've got a big audience now. But really, we want to be these guys. So, you know, the Rolling Stones have been around forever, and they just kind of keep doing what they're doing, and they are pros. And this is where I hope we get in this century with organ donation technologies and DCD, that we have a reliable, old-fashioned, world's greatest organ recovery system, or greatest rock band, depending on your perspective. I'll leave with just one other thought about innovation, which is really important to me. It's from Steve Jobs. When Apple came up with the Mac, IBM was spending a lot of money. It's not about money. It's about people, how they're led, and how much your team gets it. And I think that's been one of our take homes here in Nashville. So, Glenn and Karen, Carrie, thank you so much for this opportunity. I sincerely enjoy talking about this, and welcome everybody's questions.
Thank you so much, Dr.
Yeah.
Shaw. Truly, just an incredible presentation. So much just wonderful information in there. Just really quickly, before we get to the Q&A portion, I'm going to activate a poll really quickly. For those of you who are participating in groups, we know several of you are. If you'll take this opportunity to share with us how many are participating in your group in today's presentation, it'd be really helpful for us to get that information. In the meantime, we would love to attend to a few of your questions, as many as time allows. We have until the top of the hour, and Karen is going to help us with facilitating that Q&A. So Karen, I'll hand it back to you.
Thank you very much, Corey. Yes, there were several questions, and I just want to comment that actually I've worked with Dr. Clark when he was in Boston and actually recovered organs with him. So it's great to see that he's part of your system.
He looks exactly the same, Karen.
I know.
He's like the Dick Clark of liver transplant.
Maddening, right? One of the first questions I had is, what is the non-recovery rate when you go out to recover, and what percentage of the time that you go?
I would say, early, it's pretty low, to be honest. I think we've got a pretty good, our transplant coordinators, the ones who set everything up, have really gotten a good sense for which of the donors are going to pass, which aren't. Maybe at some point we're going to have to quantify that. So our non-recovery rate for just folks who don't, so why would you not recover these organs? So there's going to be three major reasons. One is they don't pass. And I think we're in pretty good shape on that front. Number two, something bad happens during the cannulation. There's some injury, some sort of mischief happens. And early in our experience, we had a couple of these cases. We even had another case where, a stopcock wasn't on something and we couldn't get perfusion. So there are going to be mechanical things that happen. That is pretty low now. I would say less than, over the last 50, we've maybe had 2 or 3 others that had some misadventure that surgically or technically. And then the last reason with the heart doesn't look very good. And I will say that's rare, honestly. If you get as far in, if that heart reanimates well, we usually are going to take it. So I would say of that third category, it's only been out of the, we've done 51, I'd say maybe 2 or 3 hearts we've declined past that 51 for that.
Okay, excellent. Another question they had was, should the recipient be consented when they're receiving this heart?
I think so. We're pretty open about it and have a frank discussion. We are all about transparency because we are, in some respects, feel like we're, kind of walking on the moon a little bit. But yes, I think so. I mean, the remarkable, one thing that we learned from the hepatitis C experience was that no patient had a reservation about getting these organs. And I think it goes to the fundamental issue here, which is our patients, the recipients, they are desperate. They are desperate for these organs. And so it comes back to us to find solutions for them. I've been amazed. Even this is in 2016, the antiviral drugs just came out. We didn't know whether or not they'd be able to clear their viral loads. These patients didn't care. They said, I'll take that chance. Turns out we were all right, and it's a good, happy ending. And so we've had the same experience with these DCDs, that we tell them exactly what's going to happen, and they're all for it. Similarly, on the family side, we make it very clear what's going to happen, and they, almost universally feel very comfortable.
Great, thank you very much. One question that came through, and actually a person by the name of Jacqueline Russo answered is do you know if other organs are using the NRP? And she said heart, lungs, liver, and kidney recipients are being done. And is this the San Diego that you referred to?
No, all of us are doing it. So I'll tell you that. So the San Diego and our teams, as well as the University of Wisconsin, NYU, Nebraska, there are a number of programs that are using NRP to recover their thoracic organs. But our colleagues in the liver transplant side, and I will say a lot of credit goes to all the OPOs out there that were really willing to support NRP. Well, those livers have gone everywhere. The team at Emory has put together their experience with NRP livers in the United States, and hopefully that paper will come out soon. So yeah, it's multiple programs, not just two that have utilized abdominal organs from NRP supported platforms, but a smaller number are recovering their thoracic organs with NRP.
Okay, great. There's a question that just came in, and I saw this, lots of questions were pre the presentation today. It says, are ethical challenges encountered association with the NRP recovered versus ex situ? And if so, please share what steps were taken to overcome this.
Yeah, I think this is going to be the challenge for all of us, is how do we approach this notion of reanimating these hearts when they were stopped? If you reanimate it outside the body, people are a little bit more comfortable, although it's no less an odd violation of the dead donor rule in some respects. Ensuring no brain perfusion is a really important piece that makes us all very comfortable with what's happening. But I think that there's going to need to be a little bit of help on the organizational side of things that helps clarify that these are donors that are dead, that we are not running afoul of the intentions of all the parties that are involved. I think right now we're very comfortable because the cerebral circulation is interrupted, that there is no brain perfusion. So because the heart has been reanimated, not for the purposes of saving that person, it's for the purpose of recovering the heart. I think that all fits. And again, I urge everybody to read Arthur Kaplan's editorial on this. It really nicely basically says, look, this is all acceptable. It fits within our guardrails of a civilized society because of these issues of permanence, stewardship, interrupting the cerebral circulation, and why we're doing this.
Thank you. Another question was, are all of your DCDs in your OPO performed with NRP?
For the most part. We will do both. It really, honestly, at this point, the OCS system's sort of been in between things because of their getting through their FDA approvals, but now is commercially available. So we are in a position to make decisions for each one. Frankly, from a cost standpoint, it makes more sense for us to do NRP for a DCD. But I think if there's a distance issue, if there's a time issue, if there's some assessment, as we move DCD into older cohorts, I think we'll probably pivot to using OCS a little bit more, meaning the ex vivo setup. So we have time to look at that heart, make sure that it's okay beforehand. So this is an area that we're still exploring.
When you did your presentation, you put the upper age limit at 49. Is this kind of the limit that you go age-wise, or have you thought about going beyond there? And if so, what are your
Yeah,
thoughts?
I think my team, I'm not comfortable getting past, the 40s, but I think my team is going to push me. I mean, as I have to say that, I think our success at Vanderbilt is because, we push each other. It's not just one person saying we're going to do this. So I suspect we'll start creeping in to that group, but, age over 40 for heart transplant, those donors, I mean, it's a risk factor for poor long-term outcomes. And so I think we've established that the short-term stuff looks good. We do need to start thinking about long-term outcomes. And, even with the hepatitis C experience, we're now first seeing our first multi-year survivors. And so far it's been fine, but I think that that's where we need to pivot. And I think, most of the literature on older donors has been short-term, it's okay. Long-term, we may be getting into a little bit of a problem with outcomes.
Okay. What are the criteria that you want from an OPO for you to consider a DCD heart? I know an EKG, probably an echo. Routinely, centers don't do invasive cardiac caths. What are your expectations?
Yeah, I think, as long as, we have these young cohorts, if they're under the age of 30, I'm comfortable with an echo. And really that's about it. As we get a little older, we've had a couple OPOs willing to do a cath in someone who's over 40 or about 40, or maybe had a very strong history, a diabetic or something like that. I certainly wouldn't take a DCD if we couldn't assess their coronaries if they're over the age of 40. I mean, my day job is a conventional heart surgeon, and I operate on a lot of 40-year-olds, that have coronary disease. So that'd be one thing. But, CT angiography may be a way around the invasive imaging. And so I would be very comfortable with a CT angiogram if that cleared the coronaries. And frankly, it's becoming the standard for us in conventional heart surgery. So, but I totally recognize, I mean, all of us are up against the resources of the local hospitals. And so we have to be a little practical and pragmatic about, what's realistic and what's not. I also think that the NYU team showed that it's very doable to move the donors to the recipient hospital. That wouldn't, so in Manhattan, that probably works. In our part of the country, that's not doable at all. And so, having some mobility of the donor may actually change our capabilities. There is an experience of doing angiography on ex situ circuits on the OCS system. You can do coronary angiography. So, again, maybe what we do is if we don't have the resources locally to do such things, that would push us to take a heart and put that on the circuit ex situ, and then be able to do angiography and imaging and that kind of stuff. So that's why I think we're on the verge of a remarkable period of time where we'll be able to utilize more donors than we ever thought possible.
Yeah, I think so as well. Another question is, are there more logistical challenges with travel and transport with the NRP versus the OCS? And logistical?
It's just a size stuff. You gotta have a plane, and the ambulance has got to be big enough, and it's very similar, frankly, to the OCS as far as the footprint of things. I mean, frankly, our ECMO circuit there probably has a smaller footprint than the OCS. So if you just have to, do a test run, make sure your ambulances can fit it. We use a lot of sports utility vehicles to move things around, and that helps a lot.
Okay, good. And could you explain, like, when you look at outcomes, what is the 24-hour inotrope score?
Yeah, it's an old metric. You take up all the drips and you give them a certain weighted value, and you, after multiplying by their weighted value, meaning like high dose epi is bad and low dose dopamine is not as bad, you can lump all the inotropes together to give you a sense for how much support that heart needs. And so primary graft dysfunction has traditionally been classified as what the echo looks like and if you're on ECMO. Well, I think there's more nuance to that. if you're still on epinephrine 4 days later, something's not quite right. And so that's why we're using inotrope score as a way to judge how things are going. So that 13, for example, at 24 hours, it's actually pretty low. Most of our conventional patients are in the in the 20s early, that first 24 hours. And then by 72 hours, that score drops off to 6 or 8 or something like that, which is dramatically better than our brain dead donors.
What have you learned when you've gone to donor hospitals, when you're doing the DCD recovery? What has been the conversations with the OR and the teaching and challenges that you've had there?
Yeah, I think this is where communication, even before you get there, is almost everything. And so what we've learned the hard way is that you really do need to make sure everybody understands exactly what happens. And, as time has gone on, more teams have participated in these NRP recoveries. So we have a lot more understanding ahead of time. And we also have, OPOs that are high adopters, that they've done some of the legwork already of communicating to families, communicating to teams, saying, this is going to be an NRP case. This is what it looks like. This is an OCS case. This is what that looks like. That's really been the biggest challenge, and probably the most worthy investment of our time, is to say, this is exactly what this looks like. And to ask the OPOs in the hospital, where do you feel comfortable doing the extubation? Where do you feel comfortable? Do you feel comfortable prepping beforehand? We just ask the question. We don't impose a protocol on anybody. And we work around their particular comfort zone on these things. Now, as some of the chat folks said, there's definitely work to be done. I think 10 years from now, we'll have very standardized protocols for this. And that's kind of the work that needs to get done to make this, I think, consistent and reproducible, for everybody. We still do run into times where we show up, we tried to communicate, but just didn't, what we said and what was heard was not there. And then sometimes we have to go home, and that's okay. We're still in that phase of things because by far we've recovered far more hearts than we've declined, and have saved some lives that would not be saved otherwise. And so that's been really ultimately what drives all of us here, is to look at these new frontiers, because it's the patients they are desperate. It never ceases to amaze me. Their willingness and their courage to say, absolutely, I will take a risk. And then the families of the donors who say, if you have a way of using this heart, please do. And no disrespect to my abdominal colleagues, but the heart's different. It's it's special. It has some sort of spiritual, magical properties that seem to resonate with families and patients. And so I think that's what's driving us.
Excellent. Well, I'll jump in here and allow Dr. Shaw to catch his breath. Truly a fantastic presentation. And on behalf of the Alliance, we extend our thanks to Dr. Shaw and to Karen Lord for an outstanding conversation today. I've seen several inquiries for the articles mentioned in today's program. We'll be sure to include that information in the follow-up email that you'll receive later today. Now, if you enjoyed this program, I really encourage you to check out our future programs on our website, which is organdonationalliance.org. And additionally, we have a wealth of on-demand content that you can take advantage of at your convenience. We appreciate all of you taking the time to join us for today's conversation, and we look forward to seeing you again soon. Have a great day, everyone.
Enjoyed it. Thank you.